So, I think it is 2 o'clock now. So, we will start with the topic. So, by now you have this subject, that is the system or the kidney, that we are going to learn in the subsequent classes. That the clinical implication of studying the clinical implication of studying these diseases and the basic anatomy and structure is because that you should get into why we are learning this various syndromes or the renal pathology and what is this clinical correlation, right. So, with this, so we will be covering this topic. To have a clinical correlation or clinical understanding, I have given you this as simple case history. Okay. So, looking into this clinical history, you will have what is the age, what is the presentation, clinical presentation, what we have discussed that day, symptoms and signs, and then what is the diagnosis, what are the approaches for the diagnosis, what is the pathology, what is the common disease and how it is being treated. Okay. So, this is a scenario on the basis, or this will give us, it will give us a direction that how we are going to proceed, and the topic for today is the structure of the glomerulus and the nephrotic syndrome, right. Subsequently, we will be discussing nephrotic syndrome or tubulointerstitial diseases and other conditions in the kidney, right. So, we will go to this slide again. So, here we can say that it is a 6-year boy. So, it is a pediatric case. Then he has a generalized swelling all over body, not only on the face, predominantly on the face and feet. Okay. So, this is a symptom. This patient has come to the doctor that he is feeling like this, or it is observed, he is observed this thing. Then when we are asking the further details about the case, we come to know that this is a repeated or this is a frequent episodes the patient is having. So, this is a chronic disease and the similar complaints in the past, right. So, this is something relevant. This is not an acute case or a single event, but this is a chronic disease. Then on examination, when we examine the patient, what we observe, these are the some of the signs. So, we see that the child is febrile. So, patient has a fever. Then there is again we can see there is a pitting edema on the face and the feet. Then also, so this free fluid in the present per abdomen means the patient also has ascites, right. So, this all attributes to the transudate. Okay. So, what we are getting in this case, these are all the transudates, right. Then in this clinical scenario, we want to know what can be a clinical diagnosis in this case, whether this is attributed to a renal kind of edema or whether this is attributed to any other non-renal kind of disease. Then that will be clinical diagnosis, and then you have to investigate to ascertain whether this is which kind origin of this disease. Okay. So, whether it is a kidney is at a fault, then that will be a further directions, and then what is the pathology and what is the pathogenesis, and we will then again reconfirm that this is this is the specific diagnosis for this etiology, right. So, this is how we will be going in this presentation today. So, structure of the glomerulus, what exactly at the ultrastructural level, what are the components, what do you mean by slit diaphragm, what is kidney biopsy, and we will be speaking more towards the reference to the nephrotic syndrome. What are the various terminologies used when we report a kidney biopsy, and what is the indication of kidney biopsy when we talk about kidney disease, that to nephrotic syndrome. Now, then coming to the disease proper, this is nephrotic syndrome, its definition, what are the prototype clinical features, how we classify in pediatric or adult. Then the most common pathologic events, that is very well given in Robbins, we may not be able to cover in detail, but you can refer to the books. Then we will see what are the various common types, and probably we will end with this, right. So, as we have discussed that day, kidney is an excretory organ, and we have basically this cortex, medulla, this is hilum, these are the renal vessels, and what we are interested in more is that this is basically the organ. Basically, this organ is involved in the excretion, and it also maintains the cardiac output and the filtration. So, whatever whatever the blood is brought to the kidney, it is being filtered and it is results in the formation of urine. And the functional unit of kidney is a nephron, and the nephron, how many millions of nephron are there in the kidney, each kidney? 1 million. So the nephron, which is a basic functional unit, it consists of glomerulus and the uriniferous tubules, which has this proximal, lupofenlae, collecting tubules and the collecting duct. So this all entity is required to maintain the renal function, but we will be focusing today in the part of the nephron, that is a glomerulus or glomerular pathologies, right. So basically we divide the kidney diseases into glomerular diseases and the tubulointerstitial diseases, right. This is how they are common etiologies and common events do occur. So that is why this is we divide this into these types. So what is glomerulus? That you all must be knowing. It is a tuft of capillaries or anastomosing network of capillaries invested by two layers of epithelium, that is visceral epithelium and a parietal epithelium. Then we have this capillary, intrinsic capillary wall. So we have what you can appreciate here, this is the renal corpuscle. Then you can see this is proximal tubule, you can see this is a afferent arteriole and efferent arteriole, and what you can appreciate, these are the capillary loops. Okay. In this capillary loop, there each capillary is invested by the epithelium. Okay. Now this epithelium, which is in close contact with the glomerular capillary or capillary wall, which is a visceral epithelium, which has this podocytes. Is it clear? Now the other layer of this visceral epithelium, that is a parietal epithelium, which is lining this Bowman's capsule from inside, and the space between the parietal and the visceral is the, what is it called? It is a Bowman space or urinary space, where you get the accumulation of this urine which is being formed, right. Now we are very much interested in this basement membrane. When we talk about glomerular basement membrane, we intend to say that this is the basement membrane proper, this is endothelium, and this is the visceral epithelium, that is a podocyte, right. So this is what is we are interested in when we are discussing further. Okay. So glomerulus, it is formed by the visceral epithelial cells, structurally complex, which have these interdigiting processes embedded in and adherent to the lamina rara externa of the basement membrane. So basement membrane has this one side, this visceral epithelial cells, and which have these food processes which are separated from each other by 20 to 30 nanometer. Okay. And this 20 to 30 nanometer wide, these are called this area is called filtration slit, and which is bridged by this slit diaphragm, and these are the molecules present which are important to learn. We have highlighted because these are at stake, or there is a abnormality in these molecules, so protein molecules which are responsible for the subsequent diseases. When we are talking about filtration abnormalities, that is particularly more commonly responsible with the nephrotic syndrome, because there is abnormality in these food processes, filtration slit diaphragm, and there is a passage of more number of proteins, and that is the consequence of nephrotic syndrome, right. So this tuft of, so we have this basement membrane, we have this visceral epithelial cells, capillary endothelium, and this all entire loop of capillaries is supported by the mesangial cells between the capillaries, and there is also matrix. So on light microscopy, when we look into this glomerulus, we will see this capillary tuft has these 1 or 2 cells per capillary tuft, and this we have a mesangial cells in between the capillary loop. Per stalk of the tuft, we will see 1 to 2. So whenever there is more than 2 nuclei identified in the mesangium, then per tuft we say that there is increased number of mesangial cells, mesangial hypercellulate. Okay. Normally the capillary lumen will be open, and when you compare the glomerular basement membrane, so we have to compare the basement membrane with the thickness of the tubule seen adjacent to the glomerulus, right. So that is why how we compare, whenever we say that there is thickening of the glomerular basement membrane, it means that we are comparing and contrasting with the adjacent tubular basement membrane, right. So that is how we report. Then electron microscopy is another investigation or techniques which will amplify this finer ultrastructural details, what exactly happening at the glomerular basement membrane, and that we will see. So then we report these pathologies, whether the glomerulus is partially involved, focally involved, segmental involvement, diffuse involvement and global, what are these terminology we will discuss. And apart from this, so routine light microscopy, electron microscopy and also the spatial stains. So, these histochemical stains, that is PAS stain, reticulin stain, masses trichrome, Congo red, they are generally applied when we are dealing with the renal biopsy in a particular case. Okay. So, this light microscopy, histochemical stain, immunofluorescence and electron microscopy facility if you have, that will give a complete spectrum of complete look into the kidney biopsy to ascertain the etiology, right. So, what is this stain? HNE stain. What is this stain? It is looking more pink. This is PAS stain. Okay. Then what is this stain? This is no. This is silver methanamine stain, and this is a masses trichrome stain where you get collagen blue in color. Okay. So, whenever we are interested in kidney, we have a most commonly seen is a type 4 collagen that is seen in the basement membrane. Okay. So, here you can what the normal situation you can appreciate, this is a tuft of capillaries, this is glomerulus. You can see this is parietal epithelium and this is a Bowman space, and you can appreciate this is a this is endothelial cells. You can not you are here you can appreciate the visceral epithelial cells, and in between you can this is a you can see the mesangial cells, right. Okay. So, this is on the light microscopy. You can highlight the architecture of this capillary loops and basement membrane better in the as compared to this, you can highlight better in this is a PAS stain. Also, so on so you want to highlight, you can use these two stains are complementary, silver methanamine stain where you can again see this well delineated basement membrane and capillary loops are very well identified. Okay. Again here you can appreciate. So, when there is a we want to enhance or amplify the type 4 collagen and the basement membrane, in some situation you can use the masses trichrome also. So, again in the higher magnification you can appreciate this endothelial cells here, this is parietal epithelial cells and these are the RBCs. Okay. These are the mesangial nuclei here. So, when we are looking at the electron microscopy, right. So, when we are looking at the electron microscopy, so when you are there are two types of electron microscopy, one is scanning and another is transmission electron microscopy. Okay. So, when you are looking at the scanning electron microscopy, it will give an outer appearance of the cell, how it looks on the external aspect. Okay. So, here you can appreciate this is a podocyte and these are the food processes. Okay. So, this is a scanning microscope. Again you can see this is a capillary endothelial with fenestrations. Okay. And what you can identify in transmission electron microscopy, you will see the integral details of the cellular and the cellular components of the cell. Okay. So, you want to see the Golgi, you want to see the mitochondria, you want to see the other internal components, you will use the transmission electron microscope. So, when we are going in detail about the glomerular capillary wall or glomerular basement membrane, we need to study it in detail. So, endothelial cells, there is a thin layer of endothelial cells, they have this fenestration. So, in between the endothelium there is a fenestration which is about 70 to 100 nanometer. Then we have this glomerular basement membrane which is thick, which has this thinner interna, externa and a lamina densa. Then this is a glomerular basement membrane which is consisting of more, that is type 4 collagen, and then this is the mesangium other components. So, where we are looking at this in the glomerular pathology, we are looking at the endothelial cells, we will look into the glomerular basement membrane which is consist of this type 4 collagen and the mesangial cells and the mesangial matrix. Okay. So, whenever there is abnormality anything, whether there is increased thickening or when there is a increased deposition of matrix or mesangial hypercellularity, they will give you the contributions to what is the etiology. Okay. So, when there are more than three or more nuclei in the mesangial milieu, we say that it is a hypercellular. So, this is a electron microscopic picture where you can appreciate how there is close approximation to this. These pictures are from Robbins. what you can see, appreciate here, this is what? This is a capillary lumen. Okay, here this is an endothelium, right? So, this is a capillary lumen and this is what is a mesangial cell. So, and this is a basement membrane, and in approximation to this is a visceral epithelial cells which have this food processes. You can have this small fenestration in between, that we will discuss later on. Okay. So, this is a podocyte which have this food processes. There are some slit here. This is a basement glomerular basement membrane, and this is a internal is a endothelial cell. So, we are interested in this area when we are talking about glomerular basement membrane, right. What you can appreciate here, again same capillary loops, mesangial cells, visceral epithelial cell, podocytes. This is a capillary this is urinary space, visceral epithelial cells, this is the parietal epithelial cell, this is urinary space, right, and this is what we can call it as an endothelial cell, right. These are the mesangial cells. So, the details about this filtration slit, and we will discuss in the subsequent slides where we are having the pathology. So, again you can have this filtration membrane. So, this is a endothelium, this is a basement membrane, and this is a visceral epithelium which have this, these are the podocytes. Here what you can appreciate, again this is a capillary lumen where we have these endothelial cells, and this is a visceral epithelium with podocytes. Why we are interested in, I am focusing many images for you so that you get a clear idea in various images. Now, coming to this, so again it is a replication. So, this is endothelium, we have this basement membrane, and these are the podocytes. Now, when we are going into details of the podocytes, we have this is the filtration slit through which the proteins pass when we are the function of filtration is being done. Now, this filtration slit is being is having these molecules called nephrin molecules which are binding force between these two food processes. Okay. So, these nephrin molecules are helping or to prevent the passage of some large molecules, protein molecules. Okay. So, these nephrin molecules not only, but with this the help of intracellular components, actin filaments, CD2AP and podocin. So, this all proteins together form a bond, so that there is no excretion or release or of these important protein molecules, so that they are retained, right. But when there is some pathology in these molecules, so whether there is a pathology in the or there is abnormality in these protein molecules like podocin or nephrin, then this passage will be clear and there are a lot of proteins being excreted. So, that is the importance of making you understand that what is the importance of this renal filtration unit or the filtration slit. So, after you understood the basics, we will see that when we are interested in knowing these finer details of the glomerulus or glomerular architecture, we have to have a renal biopsy. Now, what are those situations where the renal biopsy becomes a mandatory thing or mandatory step, and so what are the in general indications for a renal biopsy, where in spite of having other investigations we are asking for this bit of invasive procedure. Okay. So, what are those renal diseases where renal biopsy is advocated? So, when there is an unexplained renal failure, that a patient is not responding, this is a common one of the non-nephrotic indication. Then acute nephrotic syndrome, so they want to really know what is the exact pathology. Then nephrotic syndrome. So, all cases of nephrotic syndrome is not undergoing or they are not processed or they are not advocated or advised this investigation, right. So, in those situations, particularly in pediatric, we are not going for this renal biopsy, we are treating the patient based on the clinical and other investigation. So, and the patient is being put on steroids. Okay. So, in pediatric patient, when the patient is not responsive to steroids, so non-responsive patients of nephrotic syndrome, particularly in pediatric patients, they are taken up for the renal biopsy. Okay. But in adults they can before the treatment they can complete the workup with the renal biopsy. So, for adults the approach is different and the pediatric the approach is different. So, apart from these important conditions, these are the other indications of a renal biopsy. So, renal transplant rejection, renal transplant dysfunction, these are the commonest where the complete workup cannot occur because of this renal biopsy procedure. So, when we do a renal biopsy, these are the important things that we should have a fixative 10% neutral buffer formalin fixative for the paraffin embedding section. If you want to process with the immunofluorescence, it is a direct immunofluorescence that if fresh tissue is submitted, or if you are doing the indirect immunofluorescence, then formalin fixed paraffin embedded tissue can also be processed. And for electron microscopy, the ideal fixative is a 2.5% glutaraldehyde. Now, when we say the adequate renal biopsy, we have to see minimum 8 to 10 glomeruli, and we interpret the renal biopsy in this format. So, we have to comment on the glomeruli, we have to comment on the tubules, interstitium and vessels. So, all these two together studied will give a complete information, and not only H&E, you have spatial stain, we have immunofluorescence and the electron microscopy, where we will help you to give a definitive diagnosis, right. So, what is this meaning? So, the entire glomerulus is affected. When the entire glomerulus is affected, we call it as a global disease. Okay. When the part of the glomerulus is affected, we say it is a segmental disease. When many glomeruli are involved, we call it as a, or almost all glomeruli are involved, we call it as diffuse, and when some glomeruli are involved, it is focal. So, these terminologies are used when we are describing a renal biopsy. Okay. So, it is a diffuse disease, glomerular nephropathy, or focal segmental glomerulonephritis, so, or a global disease. So, these are the terminologies are used when we are interpreting the. So, this is an electron microscopy picture, where we can again have this look at, these are the mesangial cells, this is a capillary lumen, and the same thing, there is a glomerulus. So, why we are interested in this again and again, because in electron microscopy we see what is the location of the deposit. When there is a immunocomplex, most of these glomerular diseases are immune mediated diseases, right, and which are the primary ones. So, immune mediated diseases can be of any types, but they are mostly or commonly with the immune complex deposition. So, these deposits are where the location of the deposit we can subcategorize the diseases. Okay. So, they can be a subepithelial deposit, they can be a subendothelial deposit on this side, or they may be intramembranous deposits, or they may be a mesangial deposits. So, that is why we are interested in knowing the or learning about the electron microscopy, where we will be able to give whether what is the kind of deposit. So, for that matter, when we are saying subepithelial deposits, what comes to our mind? It may be a post-streptococcal glomerulonephritis, which may give rise to which kind of disease? Nephrotic or nephritic syndrome? Nephritic syndrome, right. So, membranous glomerulonephritis or nephropathy is can leads to nephrotic syndrome. Then MPGN, lupus nephritis, where you get a subendothelial, this commonly result into nephritic syndrome. Intramembranous, again MPG2, JN2. So, this IgA may be common for both nephrotic and nephritic. So, this is how can also help you to narrow down looking at the ultramicroscopic features, that whether membranous, then what can be the cause, what mesangial, what can be the cause, subendothelial deposit, subepithelial deposit. So, this diagram is giving you one of the narrowing information for the further delineation of your differential diagnosis. Now, immunofluorescence. So, direct immunofluorescence when we are doing. So, what information you are getting by immunofluorescence? Immunofluorescence will tell you whether there is a granular deposits or whether there is a smooth deposition along the basement membrane. Okay. So, when there is anti-GBM disease, you will see this uniform thickening of the glomerular basement membrane immunofluorescence. While when you are talking about the circulating anti-immune complexes, there is a deposition is granular. Okay. So, this information whether there is smooth deposition or granular linear deposition, along with whether there is subepithelial, subendothelial, intramembranous, then the morphology or the findings on the routine microscopy will together help you to delineate what is which disease you are dealing with, right. So, this is all is a attributed findings to come to a conclusive diagnosis. So, coming to this, so what is this I am telling to communicating here is that glomerular diseases are a heterogeneous group of diseases, okay, and they have a wide etiologies and they have wide clinical presentation. Okay. So, sometimes there may be edema, glomerular disease, there may be edema, there may be sometime hematuria, there may be hypertension. So, this is a spectrum of diseases we are getting in when we are talking about glomerular disease, right. And depending on the type of proteins or the quantity of proteins, the type of proteins and the clinical presentation, we further have categorized these glomerular diseases on whether it is nephrotic syndrome or the nephritic syndrome, that will be dealing in further classes. And each syndrome has some definitive categorization of signs and symptoms. So, when we are saying nephrotic syndrome, what comes to our mind? The primary symptoms, when we are talking about nephrotic syndrome, what should come to our mind? Patient will come to you with generalized edema. Then you will examine, you will see that there is yes edema present, that you will substantiate that by looking at the examination. Then you will see if the patient is not telling that there is ascites, you have to palpate. Per abdomen examination will tell you that yes, patient also has ascites, right. So, these are some of the findings. Then if you investigate it, you will have what in nature of investigation you will do. If in a suspected case of clinical suspected case of nephrotic syndrome, the first line of investigation will be a urine examination, right, which is a baseline investigation or a basic investigation. So, what you will want to look into the urine examination? Physical examination, chemical examination, and what else? Physical examination. Yes. So, first and foremost that you are thinking about a nephrotic syndrome, you will imagine that there is increase or there is proteinuria, and that too it will be likely to be an albumin, right. So, when you are thinking about your line of thinking is about proteinuria of renal origin, that too, in that case you will see observe the appearance, the color, whether there is any evidence of hematuria, red color. So, that will be what is the quantity, what is. So, you may also like to have a 24 hours urine sample. First you will ask for a random sample. So, the random sample will give you that this is turbid, this is opaque, right. There may not be an hematuria, it is amber in color or slight whitish in color, okay. Then you will do a biochemical investigation. So, which investigation you will do? Urine for proteins, right. So, urine for proteins is positive. So, it will be, you will like to know whether it is 1 plus, 2 plus, 3 plus, 4 plus, right, because it is given by the, which test we do for urine proteins? That is for you in the practicals, but otherwise strip test is there, okay. So, that is will give you a approximate semi quantitative estimation about presence of proteins in the urine, okay. Then what we will do the next step? You want to ascertain again, you will do the proteins, whether you will also want to see whether there is sugar is present, because sugar and proteins presence you will have some other differential diagnosis, right. So, there is sugar is absent, protein is present, protein is 4 plus, your index of suspicion is now again high. Now, what is you will the next step? Yes, blood, yes, test for blood is negative. Then, because the criteria for excretion of protein is it should be more than 3.5 grams per 24 hours. So, you need to have a 24 hour collection sample, and then you will estimate the quantity and of that it should be more than this. So, you will need a 24 hour urine sample, and then you will able to categorize. So, these are some of the essential features: proteinuria, hypoalbuminemia. So, you have to do what you will do. You will have to do the liver function test to see what is the serum albumin, what is the serum albumin globulin ratio. So, these are some of the points which will help you investigation to come to. So, these are syndromic complexes, and they have a this we have categorized based on the symptom complex as nephrotic syndrome and nephritic syndrome, but they do not have a same etiology, okay. So, they have some different details. So, in this category of syndromes, patient may have different pathogenesis, patient may have different diseases, there may be a primary disease, there may be a secondary disease. So, but patients, it is like the patient is presenting and you are narrowing the diagnosis depending on your findings, right. So, this is how we are going about these syndromes. So, what is nephrotic syndrome? It is a constellation of findings, clinical features, signs and symptoms together, where there is a massive proteinuria to the quantitation of more than 3.5 grams per 24 hours, okay, and this is gram. So, So, you should not forget this unit, this is not milligram and this is 24 hours or a day. Then or if you are doing it can be more than 40 milligram per meter square per hour. Okay. So, this can be another unit in a pediatric patient, you can have this unit or you can have this unit. Now, as there is a massive proteinuria, what it will lead to? It will lead to hypoalbuminemia. Okay. So, the serum proteins will be reduced and as a result of this there will be a edema, facial edema, pedal edema and then the generalized edema or anasarca, which is which type of edema it will be? It is a renal edema and we call it as a transudate. Okay. So, it is not the exudate, so it is a transudate because of decreased oncotic pressure because of absence of proteins, right. So, that you must be knowing. Now, because why you are getting lipiduria and hyperlipidemia and hypercoagulant, we will discuss this. So, this is what when we are saying nephrotic syndrome, we should have this constellation of findings. So, these patients of nephrotic syndrome, we generally do not have hypertension, we generally do not have hematuria, and so if you have an element of hematuria, if you have an element of hypertension, then you have to see what is the condition you are looking for. So, this is a common presentation of nephrotic syndrome. So, when we talk about nephrotic syndrome, patient will have, because there is large amount of protein being excreted, patient will have increased volume of urine, polyuria, proteinuria, then this what we have discussed, and these are the common. What is this? Minimal change, this is focal segmented glomerulosclerosis, membranous nephropathy, IgA nephropathy, membranopleuritis, these are the rare causes, these are the common causes. Okay. And in nephrotic syndrome, there is a urine output will be reduced, okay, oliguria. Then there may be an element of hematuria, if you estimate the, and the proteinuria may be there, but it is not of a higher massive proteinuria, 1 plus or 2 plus. GFR if you do, that will be reduced, creatinine increase and serum urea nitrogen, blood urea nitrogen will be increased, there may be associated hypertension. And when you look at the urine examinations, apart from physical examination we have seen a chemical examination, and when we are looking at the microscopy, what you will see, some amount of RBCs were there, if there is associated hematuria, and you may see protein cast. So, cast may be seen, but in both the cases, but our presence of RBCs or RBCs cast may be a feature of this nephrotic syndrome. Okay. So, this is just a distinction. So, heavy proteinuria, we are going into the details of this. So, heavy proteinuria quantitation we have already seen. So, what is the normal amount of protein which is released? It is lot of proteins being filtered, but they are reabsorbed by the tubules, and only about 20 to 150 milligrams of urine is proteins is being present in the urine, otherwise it is pathological. Okay. So, why we are getting increased proteins? It is because of the structural and physiochemical alteration in the glomerular papillary wall. So, that is why we are interested in the study of this and the glomerular diseases, and because there is a structural abnormality, we are seeing that there is escape of plasma proteins into the Bowman space and then into the urine, right. So, the basic etiology for this damage to this glomerular basement membrane is because of, it may be damage to the endothelium, loss of negative charges. What is the charge on protein? Anionic. Proteins are anionic, albumin is anionic. Okay. So, it may be damage to the endothelium, it may be a damage to the glomerular basement membrane or the food processes, which generally leads to damage, leads to effacement of food process. And what is the most common cause for this, or most common type of disease where you get effacement of food processes? No. Which type of nephrotic syndrome when we categorize? It is a minimal change disease, right. So, proteinuria, so we have seen, so proteinuria is there, but we have this categories. So, there is selective proteinuria where you have these small to medium sized molecules. So, along with albumin, so many proteins are being lost. Okay. So, there is transthyretin, transferritin, and sometimes large size molecule may be released, but this is the most commonly it is this albumin, then some antithrombin 3. So, these are some of the proteins which are being lost along with albumin. So, these proteins which are other minor proteins which are lost, they leads to some other associated complications in this disease, in this condition. Okay. So, we are more interested in selective proteinuria where we have a loss of albumin, there may be some loss of associated proteins. Sometimes we have this large size excretion of proteins alpha 2 macroglobulin. So, this is what is the selective proteinuria. Now, and when you talk about microglobinuria, it is around so when you know proteinuria, we should also know what is microglobinuria. So, it is the 30 to 300 milligrams of urine which are excreted per 24 hours. So, normally I have told you it is less than 30 milligram per 24 hours. So, when it is in this range, it is a reflection of microalbuminuria which cannot be detected by the conventional test what we are doing for urine protein estimation. So, now my question is, which test will help you to determine microalbuminuria? This selective proteinuria by the conventional test, strip test or heat coagulation test, right. But in this range of proteinuria, this conventional test will not detect. So, which test will help you? Anybody knows microalbuminuria and what is significance of microalbuminuria? This is a very evident proteinuria, okay. What is this microalbuminuria and what is its importance? Anybody? So, microalbuminuria is a why it is called microalbuminuria, because it will not be detected by a conventional test and we need a special investigation which is in a very lower limit of normal, okay, or this as compared to this, and we need a special investigation like a HPLC where we or electrophoresis where we can detect this microalbuminuria, right. Then the importance of this, knowing this, is that when there are some of the metabolic diseases or patient is suffering from, in that case there may be a secondary involvement of a kidney. For example, which metabolic diseases gives rise to secondary involvement of kidney? Diabetes and hypertension. So, hypertensive nephropathy, diabetic nephropathy, these are the commonest complication in these metabolic diseases, right. So, we want to detect these diseases early. So, early detection of diseases or we have to detect the early complications. So, early detection of complication can be only be possible when we have this estimation of microalbuminuria, okay. So, when we are following a patients of metabolic diseases for a long time, we need to have the follow up with this kind of investigations, okay. So, protein estimation, we have a quantitative and qualitative estimation. So, we are interested in knowing the quantity, that is more than 3.5 grams 0.24 hours, and this is the method, turbidometric method, biuret method or aspect albinometer method. So, you must know this, what is this, may be a commonly asked question, and if this facility is not available, then you can have another investigation, that is urine protein to creatinine ratio. So, you have to perform both urine protein and creatinine, and then you have to calculate the ratio. When the ratio is more than 3.5, we label it as this ratio is in the nephrotic range, and we can label the patient as of a nephrotic syndrome. So, the common question in the examination can be, if this is one of the investigation or a parameter where more than 3.5 gram per day is considered as a benchmark, then what can be the other, that is a urine protein to creatinine ratio, which can also help, because see what is the limitation of this, you need to collect a 24-hour urine sample, right. So, in those situations, if you are not able to have this 24 hours sample, then this methodology can also help to delineate the disease. So, albuminemia I have already told you. So, liver function test, we will have this parameter. So, normal plasma albumin is this 3.5 to 5.5. So, it is reduced, and the AG ratio, which is this 1.2 to 1.5 is to 1. So, albumin will be more than the globulin, but this is the reversal of ratio. So, albumin, as they are excreted in the urine, there is a reversal of ratio, because globulin remains the same or there is slight increase, but the albumin is down. So, then this generalized edema, I think we should not go into details. So, edema chapter you must have seen. So, what is the basic pathology? The pathology is decreased plasma oncotic pressure because of loss of albumin. Then there is a resultant hypovolemia, there is compensatory mechanism, aldosterone, renin, RAS mechanism, and again there is a retention of sodium and water which further contributes. So, why that day also I asked this question, the facial edema is more prominent, which is pitting, and if we later on maybe we get this ascites. So, because there is a loose connective tissue in the face, and this is early morning edema. So, once the patient is settled for night and is getting up in the morning, he will see in the mirror that there is a facial edema. So, that is an early sign we have to ask the patient also. So, hyperlipidemia, yes, why we are getting hyperlipidemia, which is another one of the manifestation of this disease is because there is loss of proteins. So, there is compensatory synthesis of lipoproteins, triglycerides and cholesterol, and this hyperlipidemic state also is because of abnormal transport of lipid, decreased catabolism, reduced lipoprotein lipase activities and LDL uptake by tissues. So, all this contributes to hyperlipidemia and there is subsequent lipiduria. So, in urine examination you may see sometimes in some microscopic examination. So, apart from urine microscopy, apart from looking at the RBCs, you can also see for this free fat or fat oval bodies. Okay. So, in light microscopy you have to lower down the condenser and try to appreciate. So, this is another important finding you may get in the urine microscopy. So, this is the reason. So, compensatory increased synthesis of lipoproteins, abnormal transport of lipids, reduced lipoprotein lipase activity. So, this also leads to hyperlipidemia and so this increased lipids hyperlipidemia is also nephrotoxic and which may cause increased proteinuria, albumin decrease. So, these are the vicious cycle, tubular interstitial injury and podocyte injury. So, because of nephrotic syndrome there is hyperlipidemia and hyperlipidemia is which is directly toxic to the kidney. So, this is a vicious cycle, right. The another consequence in a, you can may identify in a case of this nephrotic syndrome, these children they or the patients they have a hypercoagulable state. Okay. So, thrombotic episodes you may get to see in these patients. So, there is spontaneous arterial or venous thrombosis or there may be renal vein thrombosis or pulmonary embolism. So, why there is increased risk of this complication in the case of nephrotic syndrome is because there is, I have already told you, there is loss of transferrin along with albumin. Not only that, there is urinary loss of antithrombin 3, antiplasmin. So, there is a, these are what? Antithrombin 3 is what? It is a natural anticoagulant, right. So, it prevents coagulation. Okay. Any other natural anticoagulant you know in blood? Protein C and protein S, okay. That is also sometimes is lost. Okay. So, loss of antithrombin 3, antiplasmin 3 and sometimes protein C and protein S. So, these are the natural anticoagulants which are lost. There is increased synthesis of, because proteins are reduced in the blood, there is increased synthesis by liver. So, liver will compensate by synthesis of not only proteins, but also fibrinogen. So, there is hyperfibrinogenemia, there is increased platelet aggregation, fibrinolysis, decreased fibrinolysis. So, all this together gives rise to a hypercoagulable state, which is one of the important complications you get in a chronic patient of nephrotic syndrome. Then these patients also have the increased susceptibility to infection. Okay. So, what are the causes of increased susceptibility? These patients may have this staphylococcal or pneumococcal infection, and why you get this? This is again loss of proteins. Along with proteins there may be loss of immunoglobulins, altered complement factors and depressed T cell function and edema. So, all these together contribute, edema becomes a rich medium for the proliferation of organisms. Okay. So, these together may contribute for the increased risk of infection, and sometimes these patients are put on steroids, right. So, the first line of treatment in the case of nephrotic syndrome is a steroid treatment. So, again immunosuppressive therapy is responsible for the increased risk of infection. That is why we have seen the fever. Okay. So, sometimes apart from facial edema or edema all over body, they may have a fever, history of fever also. So, causes, if we talk about nephrotic syndrome and its causes, so children they are different and adults they are different. Okay. So, when we talk about primary glomerular diseases which gives rise to nephrotic syndrome in children, most common is the these are the primary glomerular diseases are 90% responsible for the nephrotic syndrome in children. In that list we have this minimal chain disease, focal segmental glomerulosclerosis, rarely membranous proliferative. So, these are the diseases which are commonly leading to nephrotic syndrome in pediatric population. When we talk about adults, in the list of primary diseases we have this focal segmental glomerulosclerosis, membranous glomerulonephropathy, then proliferative glomerulonephritis or IgA type, and this. So, this is the list. So, these are the commonest causes of nephrotic syndrome in pediatric and adult population which are primary. Now, what are the systemic or secondary causes of nephrotic syndrome? That question may be asked. So, it may be metabolic disease like diabetes, amyloidosis, SLE, or there may be some drugs like non-steroidal anti-inflammatory drug, penicillamine, gold. So, these are some of the Ayurvedic medication patient may be undergoing some treatments. Apart from that, infections like syphilis, malaria, hepatitis, HIV, and so this is other rare causes. Okay. So, children systemic diseases are less common as compared to adults. So, coming to the pathogenesis, so the glomerular injury in most of the cases is a immune mediated injury, right. So, it can be a primary, that is, and this is the most common cause of primary diseases. Secondary we have already seen. Now, in the category of immune mediated diseases, it may be an antibody mediated disease, it may be because of circulating immune complex deposition which can be endogenous or exogenous, or it can be a cell mediated type of immune reaction. So, these are the three basic kind of events which may lead to glomerular injury. So, antibody mediated, circulating immune complex deposition, or there may be a cell mediated injury. So, when we are talking about immunofluorescence, so whenever there is circulating immune complex deposition, it is generally a granular deposit. When it is an antibody which is directing injury towards a planted or a fixed antigen of the basement membrane or a component of the basement membrane, it is generally a linear deposit, smooth linear deposit. So, we have this two forms of antibody associated injury, deposition of soluble circulating antigen antibody complexes. Okay. So, that there is no pathology in the kidney itself, it is the end result of some pathology occurring somewhere else, like we see in SLE. SLE there is no pathology in in exogenous diseases, like particularly in streptococcal diseases. Okay. So, streptococcal infection can occur in somewhere else, but these antigen antibody complexes which are occurring, they may go and land up into the kidney and there is no primary glomerular disease. So, there may be a deposit antinuclear antibody form into the, in case of SLE, which may get deposited to form antigen complexes, which may be a antibody complexes formed of the body itself, while this is antibody complexes formed because of the exogenous organisms, like I have told you, bacteria or viruses. So, this is and particularly in membranes there is no inciting antigen is known. So, this formation of antigen antibody complexes where there is no primary injury or pathology in the kidney, that is the deposition of soluble circulating antigen antibody complex is one of the etiology. So, here what you will get in glomerular lesions, you will get that there is leukocyte infiltration or exudation into the glomeruli, then there is associated proliferation of endothelial cells, mesangial cells and epithelial cells. So, this will together will cause a hypercellular type of glomeruli. Okay. So, hypercellularity because of leukocyte and this proliferation of various cells, and this will be, you will appreciate in the light microscopy. What you will see on the electron microscopy, you will see immune complex deposition, that are that endothelial depositions as clumps. Okay. And there may be a mesangial deposition or some endothelial deposition or subepithelial deposition. So, this finding immunocomplex deposition as endothelial deposits, electron dense deposits can be at the various location, it can be mesangium, subendothelial or subepithelial. So, this will be the finding in case of a electron microscopy when we are talking about the circulating deposition of immune complexes. Then another antibody mediated injury will be a injury by the antibody itself. So, in that case there is an in situ antigen of the glomerular component. So, now the antibodies form again the component of the any of the component of the glomeruli. In first setting what we have seen, there is no pathology in the glomerulus, it is the complex which is formed somewhere else and getting deposited into the kidney, right, in the glomerulus. In this situation the antibody is targeted directly to the some of the components or antigens of the glomerulus reacting in situ antigen within the glomerulus. It may be insoluble, intrinsic fixed, or it may be a molecule planted within the glomerulus. Okay. So, this is against the various components, whether it is a podocyte, whether there is a basement membrane that we will see, or there may be a epithelial cell. So, here what you can here just we have what we have discussed, there is circulating immune complexes, it may be deposited subepithelially, it may be deposited subendothelially, or it may be in the basement membrane itself. Here what you can see, there is in situ anti-GBM antibody. So, there is an antibody directly against the glomerular basement membrane, or this is another antigen where there is a Hammond type of in situ antigen, where you are getting here it may be subepithelial or there may be a intramembranous deposit. So, anti-GBM will be a intramembranous kind of deposition of these antigen antibody complexes. The third and last is a cell mediated kind of immunity, where the sensitized T cells. So, cell mediated immune reaction can also be responsible for the injury of the glomerulus, and it is said sometimes that first to begin with it may be antibody mediated and later on it may progress to the T cell mediator or cell mediated immunity. Then so, how will you identify that? There may be a presence of activated macrophages or activated T cells which are seen in these sites, and that can be responsible for this injury. Now, in glomerular nephritis, in this kind of cell mediated injury, you may not be able to find out the deposition of immune complexes. Okay? So, if you try to identify them in the electron microscopy or immunofluorescence, you may not be able to identify when there is this kind of pathology. So, this is a diagram from the Robbins, where you can appreciate this is antibody mediated disease, where there may be epithelial, endothelial or mesangial deposition, and when there is a T cell immune mediated reaction, there may be T cell mediated pathology in the, they may be affecting the platelets, macrophages and mesangial cells, and then there is a release of these proteases, growth factors, nitric oxide, and then together they damages the glomerular components. Okay. And what I was talking about, we have seen this filtration slit, and when there is a food processes, loss of food processes, there is effacement of food processes, we will see this, there is a loss of protein. So, that is an important finding when we talk about loss of this nephrin or the podocin. So, there are some genetic basis of nephrotic syndrome. So, when the molecular at damage, that is I have told you just now, nephrin or podocin, we have this. So, it is about 3 to 5%. When NPHS1 gene is involved, it may be encodes the nephrin. So, there is a pathology in the nephrin molecule, and it may be responsible for the congenital nephrotic syndrome of Finnish type, and it is generally a steroid resistant, and patient may have a recurrent proteinuria, and these patients may require a renal transplantation. This is when there is NPHS2 kind of disease, which is autosomal recessive and which encodes for this podocin. So, when there is a pathology in this molecule of podocin, we have this, it will result in a kind of disease which is a focal segmental glomerulosclerosis, which can also be resistant to steroids. So, these, when there is a genetic basis and recurrent, you have to investigate it in this line also. So, first line of treatment will be your steroid. Then you will see what is the age group, it is a congenital disease, you are getting a congenital kind of nephrotic syndrome, then you should, your index of suspicion should be high, you have to rule out or see for whether there is molecular pathology involved. Okay. So, this is understanding is because they may be a steroid resistant, they may be complicating, and they may patient may have require a renal transplantation. So, nephrotic syndrome can sometimes be a complication of other diseases. So, this is a list of diseases where you may have a secondary complication. So, as I have told you, immune dysfunction is more common, that is a recent hypothesis which damages the visceral epithelial cells, release of inflammatory mediators, loss of glomerular polyions, and this congenital nephrotic syndrome, and maybe because of this mutation in this podocin or nephrin, and these are the another two. So, that we have seen this diagram. So, there is a loss of this nephrin molecule and this podocin molecule. So, ultimately this filtration slit will be abnormal, and there is more filtration of proteins. So, minimal change disease is one of the most common cause of pediatric nephrotic syndrome, which is frequent in this age group, and it has this immunological basis. So, what is the exact pathology? There is a diffuse effacement of food process of visceral epithelial cells, we have discussed at length, and what is This patient generally have a associated with, they may be secondary to some infection or post immunization. Okay. So, that may be, and they generally respond. Okay. So, the minimal change disease, we did not have to go for a renal biopsy. Okay. Depending on the clinical scenario, you can directly put the patients on steroids, and if the patient is not responding to steroids, then you can do a renal biopsy, and then later on you can put the patient on immunosuppressive treatment. So, on light microscopy, why it is called minimal change disease? Because on a routine conventional light microscopy, you may not be able to appreciate, because loss of food process is a phenomena which can be appreciated on the electron microscopy. Okay. So, on light microscopy, glomerula may appear normal. Electron microscopy, you will see the glomerular basement membrane is normal, there are no deposit, but the only thing you can appreciate is the loss of food processes, uniform or diffuse effacement of food processes, and that is because of the flattening, retraction and swelling. And this patient generally responds very well to, and the change can be reversible, respond to steroids. Okay. The other, so here what you can appreciate, this is what? This is a visceral epithelial cell podocyte. What you can appreciate, there is a loss of this podocyte food processes, otherwise glomerular basement membrane and endothelium is normal. Here you can appreciate, this is a podocyte, this is a visceral epithelium, sorry, this is a capillary loop, and you can see this endothelium, this is a basement membrane, and this is a podocytes. Here you can appreciate there is a complete loss of podocytes in this case of nephrotic syndrome. So, in minimal change disease, you can appreciate the glomerular looks normal, the tubules look normal, and here what you can appreciate on clinical on electron microscopy, loss of food processes, right. What class you have after this? Micro. So, this is a clinical spectrum which we have already discussed. So, these patients of minimal change disease have a good prognosis. Other common condition is a focal segmental glomerulosclerosis, when sclerosis of glomeruli which are less than 50%, and there is only a portion of the glomerulus, that is segment of the glomerulus is involved, that is a focal segmental glomerulosclerosis. It may be idiopathic, immune mediated, or this can be a secondary disease like HIV, sickle or obesity, or this drug induced. Okay. So, what happens here is there is epithelial damage which is a hallmark, and there is a they may be associated genetic defect. We have seen whether it is podocin or what was it? Focal segmental glomerulosclerosis, it is podocin or nephrin? Nephrin. So, and these are some of the genetic defect in this component of slit diaphragm. There may be, first time there is to begin with, there is hyalinosis, the entrapment of the plasmaceous material. Later on there is deposition of extracellular matrix which leads to sclerosis, and there is circulating cytokine may be found in these patients, and these patients may have recurrent proteinuria and they may land up in complications. So, we have to put the patient on transplant. So, these are some of the variants of focal segmental glomerulosclerosis. Collapsing variant is a feature of HIV. Okay. So, this is a focal, some glomeruli is involved, and this is a segment of the glomerulus. So, this you can see hyalinosis and sclerosis. Membranous glomerulopathy, this is a common cause in adults. In pediatric, it is a minimal change and a focal segmental. In adults, focal segmental and a membranous is common, and this may be some of the secondary causes. It is immunocomplex mediated disease. There may be autoantigen to some of the receptors of the glomeruli, and this again the inflammation mediated injury. So, there is uniform thickening of glomerular capillary walls, subepithelial deposits on electron microscopy along, there may be effacement of food processes, and you may see some diffuse thickening of the glomerular basement on routine HNE. Then granular deposits, immunoglobulin complement may be appreciated in the immunofluorescence. So, what you can appreciate here is, you can have this immunocomplex deposition at the subepithelial level, okay, and this is a thickening of the membrane, this is a membranous glomerulopathy. So, you can appreciate this is normal glomeruli, you can see very fine glomerular basement membrane, you can appreciate is a thickened glomerular basement membrane, you can see this thickened glomerular basement membrane. See immune complex deposition along the subepithelial end, and you can appreciate this thickened. So, this is what is, so this immunocomplex deposition will give rise to, I have told you earlier, granular deposits in immunofluorescence. You can see irregular granular deposits. So, these are generally non-responsive to steroids, and renal failure can be seen in 20% of cases. So, HIV associated nephropathy, most commonly it gives rise to collapsing type of focal segmental glomerulosclerosis. Here you can see this collapsed tuft of capillary loops. आगे क्या सर? किसका क्लास? किसका है? कौन आया है? So, this is collapsing glomerulopathy, and this is membranous proliferity. So, this you will be covering in next class also. So, you can appreciate this wire loop appearance. So, unique thickening of the basement membrane, prominence of capillary loops and dense loop, deposit disease. Okay. So, this is can be seen in type 2 MPGN. So, these are given, diagrams are given in the book, you can refer. IgA nephropathy is again a common cause of adult, one of the common cause of adult nephrotic syndrome, and this you can again discuss in the next class. Okay. So, you can take the attendance. So, you can appreciate here, I will just move through these images. So, this is what is that this disease is. What is this? Okay, next time I will show you these images, right? Just take the attendance.